Let's shift gears one more time and talk a little bit about relevant or potentially actionable mutations in squamous cell lung cancer. Squamous cell lung cancers, for better or for worse, haven't shared the same advances or haven't had the same treatment paradigm as the adenocarcinoma population. The mutually exclusive genetic alterations with an adeno is such a clean, nice story where you can wed these drugs based on the target that you define. I don't think we've had that really with the squamous cell population. Things may be changing. Govindan maybe can give some historical perspective from your work in the TCGA Atlas and then kind of fast forward in where you think we're heading here.
Sure. The Cancer Genome Atlas looked at 500 squamous cell lung cancer, and we found that there is a potential, the critical word is potential, a potential molecular alteration that we can go after in about 2/3 of our patients. But then they are not your straightforward EGFR mutation, ROS fusion, or ALK kinase alteration. And these actually involve predominantly tumor suppressors. In fact, the two most common alteration we find is a CDKN2A loss, which is a tumor suppressor, and P53 loss. And these are not easily targetable at the moment, but potentially some of our cell cycle inhibitors, CDK4/6 inhibitors, may have a role in some subpopulation of these patients. The other thing, we do see in about 7 to 10% FGFR1 amplification, and there have been some fusion events, the FGFR3 TAC3 fusion that has been reported in a very small number of patients, but those patients are very sensitive to FGFR inhibitors. And we also see alterations in PA3 kinase PTEN and that pathway, but that area has been a bit of a challenge in terms of drug development, and we have not seen much activity there. And then, as you may know, there is some alterations in DDR2 and other things. So what we've learned is that potentially these things are something we should target, but we should put in some effort to think creatively. But that may be superseded by what's happening in the immunotherapy world. And so we don't have to always have a targeted therapy. Right. At the end of the day, it's only a means to an end. So I think hopefully we will be able to bypass that.
And in terms of the lung map trial and trying to define targets to wed particularly genotype-driven therapies, where are we with that? And will that help answer some questions, or is immunotherapy kind of just squashed a lot of the efforts?
I think we should do both. I don't think one should exclude the other. And I really commend the leaders of the Lung Map program, and they've been very nimble, and they've been able to move forward and adjust to the reality and change the study design. And so that is going forward. It's open in many centers. The NCI has put in a lot of money and effort in getting this, moving this forward. I think those trials are ongoing, but we don't have a finite answer for any of those particular pathways.
Right. And do you think in the end, if you had your squamous crystal ball here, do you think it will be single drug with target, or is the genetic complexity really factor in here? Will probably be target with chemotherapy or another strategy moving forward?
I think obviously for sure chemotherapy that helps patients. Immunotherapy definitely yes in that 10-20%, and we'll be moving forward. I'm hopeful that we'll be able to approach the tumor suppressor loss in unique ways that we are not right now thinking of. And so I won't take that off the table right now.
Okay. Testing for EGFR and ALK and squam. Is that something that we should be routinely recommending? And Mark, can you give your perspective?
Well, again, if you do a comprehensive genetic profile to look at the various abnormalities that Govindan just talked about, you'll get that automatically. If you go to the NCCN guidelines today, though, they do recommend testing of squamous cancers in never smokers, and also in those patients where you have made the diagnosis of squamous cancer on a tiny biopsy, because there's the most variability in small biopsy specimens. But I hate to sound like Mr. One-Size-Fits-All, but maybe I am. I would just test everybody, because you just don't
irrespective
really know
of clinical
for sure.
phenotype for the squamous cells.
Well, there's no clinical phenotype, really. But that's what the guidelines say today. I would just test folks, and then you have this information, and then when ultimately a trial comes up, or ultimately when one of these agents becomes available, you're ready to rock and roll, and you do find these other abnormalities.
You know, what's nice about the lung map trial actually is that's what they're doing. That's been incorporated in some of the changes where they're testing everybody even during first-line therapy, so that then they find these abnormalities and hopefully get targeted therapy if they have one. And that's what we're trying to do at Yale, is when we see patients with squamous cell cancer, put them on this trial, test them comprehensively, and and try to find a targeted therapy that works.
Yeah, I think that we, for patients who are light smokers or never smokers who are squamous cell, we are routinely testing and then considering testing for other squamous cells. And we've picked up some EGFR and ALK that I would have never thought. Mixed histologies, heavy smokers, we've picked these up, and it has helped drive decision making. So I think the effort should be on to really genetically interrogate those patients as well.
So is there any data that these abnormalities change after first-line treatment
In terms of targets?
in terms of target?
You know, there are things found present in what are called the founding clones. These are the critical genes that cause the transformation of the cell, and they will be there. In fact, we have done over 30 specimens before and after EGFR TK inhibitors. Not one time I've seen the disappearance of the founding sensitive clone. And so the causative lesions will be there. The subclones may evolve, come and go, like T790M may come and go. But the critical lesions like the CDKN2A and others, I suspect will be there in squamous, and EGFR and ALK will be there all the time.
Because with treatment, we are seeing a reduction in copy numbers and overall, so there may be actually a change in, at least as you just said, maybe it's not the change in the driver, but also in
Quantitative
subclones,
change,
right?
maybe.